correct a scoliosis, you've got to get the normal curves back into place.
So that's what we're going to be kind of going through here. And I've actually spent quite a bit of time putting this together because I had to take all the other stuff I had and kind of bring it down into one area. Most of you are familiar with CLEAR Institute. It's the Chiropractic Leadership, Educational Advancement and Research Institute that I started in St. Cloud, Minnesota about 8 years ago. The whole purpose of that time was to improve the quality of chiropractic. And what God just kind of did is led me into this whole thing with scoliosis instead. Well, maybe not instead, that was the plan all along. But we've been seeing some incredible things going on with scoliosis and with the spine itself. As chiropractors, we really need to be spinal experts, don't we? And not just hit, hope, pop, and pray. I've talked to both Dr. Greg and Dr. Ben about this too, and he says he wants you guys to be better than the average chiropractor down the street, right? So there's a reason why people will come and see you, and that's what we're going to look at this morning. How to be a better doctor, how to help our patients more, and not just on a symptomatic basis. Chiropractic should not be a chiropractic aspirin where you get a headache and get adjusted and you feel better. When we start looking at the whole thing as far as wellness care, wellness really means getting that spine functioning normally, doesn't it? The truth of the matter is that chiropractic always works 100% of the time. It's the chiropractor that doesn't always work. As a matter of fact, morning. St. Cloud is very close to Northwestern College of Chiropractic, which is now Northwestern Health Science University. And what they really do there is they teach the art and the science of chiropractic and not the philosophy. Because their idea is, well, we're just going to turn them into trained doctors in a sense. But what we have with chiropractic is really special, isn't it? I mean, when it comes from above down, inside out, and we see what can happen as far as health goes, it's just phenomenal. So we really want to focus on the whole thing with chiropractic and that spine. And that's what we're going to be doing this morning because it is so important. First thing we want to do is look at the spinal model. Before we can understand the abnormal, we have to understand the normal, don't we? Make sense? In other words, if I want to be able to fix the spine, what am I going to fix that spine to? Where am I going to go? And I have to have a vision in my head of what the normal is so that I can take the abnormal to that position. Now, when we look at the spine from the side, we know there's supposed to be normal curves here and then a straight spine here. Makes sense, doesn't it? Anybody here have the spine figured out yet? I don't. And there's a reason why. When we start to look at the spine, we have 7 cervical vertebrae, 12 thoracic, 5 lumbar, so that's 24 vertebrae. Then we've got the sacrum below that, that's 25. We've got the head on top, that's 26. We've got the left hip, 27, right hip, that's 28. There's 28 variables in the spine. How many letters in the alphabet? And how many words can you make up? Now, I'm not sure that insanity is hereditary, but my son Josh is at Parker Chiropractic College right now, and he took 28 to the 28th descending power to see what this really comes out to as far as what we're looking at with the spine. And it comes out to 304 octillion, 888 septillion, 344 sextillion, 611 quintillion, 714 quadrillion variables, and after quadrillion, then we start to look at trillion, billion, million, and thousands after that. See why we can't figure the spine out? But isn't it incredible how fearsome and wonderfully we are created? When you look at what God has done and put this whole thing together, and we can't even imagine it with our finite minds. So what we really need to do is keep it simple, stupid, right? Boil this down into stuff they can really understand. So when we go back and look at some of the techniques originating even with Grostic, what they did is that type of line drawing analysis. And Pettibone went into this, Harris, and a lot of the other techniques. So we start looking at the spinal units. Now, there's 6 spinal units that we're looking at. Basically, the upper angle, which is the head in its relationship to the atlas. What we need to do is be able to visualize the spine three-dimensionally. In other words, this headline and this atlas plane line here are the same as this headline and the atlas plane line there, just another dimension. So that's the upper angle. Then we've got the lower angle, which is the atlas and the upper cervical spine, pretty much C2 down to C5 area, or the stress vertebra. Same lines here, just another dimension. Then we've got the upper dorsal angle, which is C5 down to T7. Same line, just another dimension. And then we have the lumbodorsal angle, which is T7 down to L3, lumbosacral angle, which is L5 to L3, same line, another dimension. The sacrum and the pelvis then, sacral baseline, kind of a gravitational weight line to represent that pelvis. It's much easier for me to control 6 units than 28 units, right? There's a reason why we don't have 28 kids, we stop at 6, right? All right. When we start to look at this spine, part of our problem is that we're looking at it segmentally, and it's not a segmental thing. It's all connected here. So when I look at this normal spine, what we're really seeing is this whole thing functions as a unit. So here we've got the head, then we've got the upper cervical spine. Really, if we look at it, the thoracic spine actually goes from C5 to L3, doesn't it? At least 1/2 of L3. So biomechanically, there are 17.5 thoracic vertebrae. There we go, changing your education again. So when we start to look at it as spinal units, it starts to make a lot more sense. But we have to be able to visualize this whole thing three-dimensionally. I pretty much drive my patients crazy because I do movies in my head of their spine and of the normal spine, and I run it in fast forward, and then I have to go back and play it in reverse to go back to where I want to be. So I'll be sitting there looking at a patient, and what I'm doing is visualizing their spine up here, and I kind of freak them out because I'm really not seeing them. I've got all these little movies going on in my head. Okay. I taught a seminar up in Toronto a few years ago on scoliosis, and I was explaining to people, the doctors there, how I came up with this stuff. And when Dr. Lawrence came up to me afterwards, he said, "Dennis, you can't do that." And I said, "What?" "Well, you were starting to scare people with the way that you think." All right? But visualization is very important. So we know we should have a normal curve as far as that spine goes. The curves are very important to the spine. They give the spine strength and flexibility, don't they? Which is really important. Now, Jay, you're pretty strong. Grab the bottom of this here for me, okay? Now, with 2 hands, okay? We're about the same age, but if I try to turn it right now, I can't do it. As soon as I put that curve in there, I can make Jay look like a wuss, see? So there's a reason why those curves became there, why they developed, and we're going to take a little bit of a look at that as well. So this is a normal cervical curve. Now what we have to realize is that the spinal canal and the spinal cord goes posterior to the vertebral vertebra, doesn't it? Behind the vertebral bodies. So as it becomes straighter, it actually gets longer. So here's the biomechanical aspect of the spine. Here's the back, here's the front, here's the brain and the spinal cord. And the brain and the spinal cord are attached, right? So as it becomes straighter, see how it gets longer? Well, guess what? The spinal cord will only inherently stretch 10%. If we go from a cervical neck to a military neck, there's a 10% increase in distance. When you go into a kyphotic neck, it increases about 17% in distance. And when we go to an S curve, either a lordotic S curve, which would be like this, or a kyphotic like this, it can actually increase about 28% in distance. Now, Jay, you get it for sitting up front, but if I took Jay's finger here and made it 28% longer, so here's halfway, here's a quarter, so I'm going to stretch it from here out to here. Jay's going to complain a little bit, isn't he? As a matter of fact, only 30% of the nerves in our body are actually pain-sensitive nerves, aren't they? The other 70% is communication nerves. So when we start getting this compression, this pulling on the spinal cord, what the body will try to do is react to get away from it, and that's where we start to see the scoliosis. Now, I'll be touching on scoliosis, but what you're going to see is by doing a lot of these things, we can not only prevent scoliosis. V.J. Palmer, in his chiropractic technique book in 1920, said, and remember he had the second largest osteological museum collection, he said that 25 to 30% of the population has scoliosis. That's a lot of your patients, isn't it? We've kind of a tendency to ignore it. Now, the next thing, when we start to look at this, is we can see how that puts abnormal biomechanical tension on the spinal cord. We have the meninges that goes around in the brain and the spinal cord, don't we? The meninges is composed of pia mater, arachnoid mater, and dura mater. Everybody's heard of meningitis. Okay, so this is all related to the patient. The thing is that the dura mater, what's dura mater mean in Latin? Tough mother. You guys had a rough childhood just like me, right? Okay. The dura mater is composed of diagonal fibers, and they don't stretch a lot. So when you start to look at the dura mater, what happens as it becomes straighter, it creates a pincher effect, a compression, a squeezing of that area. So we get to pass these around. So hang on just for a second. So if I take Jay's finger and make it 28% longer and I'm squeezing it at the same time, do you think he's going to like that? Do you think the nervous system, the spinal cord likes that? Now again, the dura mater, the meninges, goes around the brain, doesn't it? And attaches to that cranial vault in that area. So when we start to go from a lordosis to a kyphosis, it's stretching that dura mater around the brain. It's like when you get up in the morning and you put your sock on, but you pull it so tight you hurt your toes. Anybody else do that? Okay. So it definitely has incredible ramifications with the whole thing with the brain as well, which is why I've been looking into a lot of the cranial adjusting. It just blows me away, because we can release some of those meninges with some of the cranial subluxations. But that's the next seminar. Now, believe it or not, there's a lot of research that actually talks about this, but we seem to ignore it. This is out of Spine in 1998. It says between a neutral position and full flexion, C2 to C7, that it elongates 10% in the front and 6% in the back. The average displacement was 1 to 3 millimeters, upper cord moved caudal. This study further supports using rehabilitation of cervical lordosis as an outcome assessment. Can we get that curve back in the patient's neck? There's a big difference in dentistry between the guy that is doing orthodontics, as far as bracing with the kid's teeth, compared to the drill and fill guy, right? Okay, guess who makes the most money? Yeah. We don't want to be symptomatic chiropractors. We want to be, well, okay, I want to be a structural chiropractor. I can't speak for you. I want to be able to see changes in this spine. Now here's another one, dynamic studies of cervical spinal canal magnetic resonance imaging. As compared with extension, the cervical spine canal and spinal cord lengthen 12 millimeters in average during flexion, whereas the spinal cord lengthens 28 millimeters in average, which means a difference of 15 millimeters. So there's a stretching of the entire spinal cord. Remember when you've done like ranges of motion tests on somebody and they put their head down into flexion and they have leg pain? Well, there's a reason for that. That's the spinal meningeal tension test, okay? But we're taking that dura mater and constricting it again. Biomechanical aspects of subarachnoid space. At flexion, a narrowing of the ventral subarachnoid space of up to 43% and a widening of the dorsal subarachnoid space up to 89% compared with the neutral position. At extension, an increase the diameter of the ventral subarachnoid space of up to 9% was observed, whereas the dorsal was 17%. So what they're saying here is going back to this with that dura mater, is that as it becomes straighter, it has a pressure effect upon the spinal cord. It's pinching that spinal cord, isn't it? It gets better. At flexion, there was a reduction in the sagittal diameter of the cord up to 14%. Okay. This is a new article I found. It came from Neurosurgery in 2005. Stretch-associated injury in cervical spondylitic myelopathy, a new concept in review. At the cervical-thoracic junction, significant axis strains occur in the cervical spinal cord. Where flexion is greatest, the spinal cord stretches 24% of its length. How much does the spinal cord stretch? 10% inherently, okay? So, but there's a 20% increase in this causes local spinal cord strain. Now, we've heard of ankle strains and ankle sprains. What about a spinal cord strain? Whole different thing. What we are doing in chiropractic is really out there, people, but it's much greater than we can even envision. So here we've got that flexion position. Biomechanical aspects of the cervical cord, effects of postural. What they do is the area in cross-sectional view of the cervical cord, which is ACSCO. So they're looking at that cross-section of the cord. And what they're saying here in the recombinant erect series, it was larger in extension, but actually smaller in flexion, which we understand. This blew me away. This just came out of an article, effects of flexion, extension, movement of the head and spine and spinal cord and nerve roots. I just found this. In spinal flexion, Reed measured the anterior component of force exerted by the cord and dura at different levels and found the anterior component of the force reaching maximum values of 30 to 40 pounds per square inch. Now what we're talking about again here, as we go into flexion or go into a kyphotic neck, we're going back again here, where with that dura mater, what it does is starts to squeeze that cord up to 30 to 40 pounds. Remember Dr. Sue at the University of Colorado years ago did all that study and said it takes 6 times less pressure to affect a spinal nerve than a peripheral nerve. So we're talking about 30 to 40 pounds of pressure on the spinal cord. Do you think that's going to affect the ability of the body to relate to its environment? You think health could actually be damaged because of that? I think that's phenomenal. And they knew that back in 1960. Now, coming down on the airplane yesterday, I found another article I finally had time to read. It's relative shortening and functioning tethering of spinal cord in adolescent scoliosis. But again, this has ramifications with all our patients. Results of asynchronous neuroosseous growth, summary of an electronic focal group debate of the IBSE. This came out in June 27th of 2008. And I actually have the article right here. Diagrams from transverse sections through the spinal cords at T3 of cadavers in forward flexion and extension showing the rounder shape of the cord and extension. This is the spinal cord in flexion. This is the normal spinal cord. You see how that's being compressed? These are actual pictures or diagrams drawn from the cadaver. Now, the next thing we have to realize when we start to look at this, and they call it anterior spinal growth from T1 to T12, stretches the normal length spinal cord cranial and at the cauda equina, leading to hypokyphosis, loss of kyphosis, okay? From anterior component of force with maladaptation of the growing thoracic spine to the tethered spinal cord with subtle neurological dysfunction. What they're saying here is that we know that the dura mater attaches to the cranium and probably C2, and then it doesn't attach until it gets down to the filum terminale, right? So everything in between here, but it is attached. So as I take the top and the bottom and pull it, it's like a tug of war. Everything in the middle gets tightened, doesn't it? So it affects that entire spinal cord all the way down with that compression and that lengthening we're talking about. So it's kind of pulling from both ends. Now, this is from the same article. Spinal flexion extension at the spinal cord, it unfolds and it folds. It does not move up and down actually in the spinal canal, but adapts to varying length of the canal by plastic deformation. So when you go into someone with a kyphotic neck, it's not like the spinal cord is moving up and down, okay? It has a tendency to fold and unfold on itself because it's attached on the top and the bottom. And then the spinal cord itself will change through plastic deformation. Lengthening, inflection, shortening, and extension. The cervical cord inflection stretches the most 24%. How much will the spinal cord stretch inherently? 10%, and that's it. So something has to happen there. The length of the spinal canal increases up to 18 millimeters at C8, T5 roots on forward flexion. How much is 18 millimeters? It's about this much, right? Okay. There's 25.4 millimeters in 1 inch. So we're looking at about 3/4 of an inch of pulling. So again, if I take his finger and make it 3/4 of an inch longer, okay, and squeeze it at the same time, he will complain. What was interesting in girls with scoliosis, they found that it actually lengthened 20 millimeters. They found physiological lengthening of the cord and dura chiefly between C2 to T1 up to a maximum of 17.6%, and the anterior component of force which reached maximum values again of 30 to 40 pounds per square inch. So again, it's that compression directly on the spinal cord. Now this part is really cool. A significantly lower cerebellar tonsil level and abnormal SEP findings were found in the subjects when compared with the controls. The brain and the spinal cord are connected, right? Now, unfortunately, when I was at Palmer, I was taught that BJ's teachings basically stated at that time is that the medulla oblongata comes down to C1 and C2. Well, it doesn't. And I've got the slides to prove it. That's another part of this other scoliosis seminar. But what we do have at C0 and C1, that area, C0 being the occiput, is spinal cerebellar tracts. What we're looking at here is that the brain sits on top of this, okay? Now, when we go into flexion, what happens is the cerebellar tonsils get pulled into that spinal canal area, below the BO, the basilar occiput area, which is really weird. That shouldn't happen. And then they're also seeing these abnormal SSEP findings as well. Now, in a practical application, what they found is that kids with scoliosis, in mild scoliosis, 14% of them had cerebral tonsils pulled below the foramen magnum, very simply put. In severe scoliosis, 43% had these cerebral tonsils pulled lower. So again, when we start to go into a kyphotic neck like this, what happens is that tension starts to pull it down into the spinal canal, doesn't it? Now, what I find very interesting is with kids with scoliosis, 90% of them have a severe loss of cervical curve and forward head posture. And I'm not even sure about the other 10%. They might too, okay? But it's rare to see that type of such a severe bad loss of curve in a kid's neck. So we start to see abnormal things going on with this. Anybody know Dr. Scott Rosa? He's a chiropractor in New York. I've had the opportunity to talk with him a number of times because he's doing some new things now with MRIs, and it's a new type of MRI reading, but he's actually able to go in there and start measuring all kinds of things that are going on in the upper cervical spine, C0, C1, C2, with MRIs that are never done before, including measuring the cerebral tonsils, cerebellar tonsils. And what he's saying, especially in whiplash injuries, any of your patients ever been in a whiplash? In whiplash, what happens is it goes into, well, really what happens, it goes into a kyphotic S-curve and then flexion and extension. But he's saying in a large amount of whiplash accidents, we see these cerebellar tonsils pulled below the foramen magnum. And he's able to verify and substantiate this with MRI. And he's working with a lot of different people to do this. We could go into alar ligament damage and all kinds of really cool stuff. But he's also substantiating this whole thing as well. Now here's another article. We're jumping to another one. This was out of JMPT. Patients with a lordosis of 20 degrees, and we're going to teach you how to measure that this morning, or less, were more likely to have cervicogenic symptoms. The odds that a patient with severe pain had a lordosis 0 or less was 18 times greater than a patient with non-cervical complaint. Patients with cervical pain had less lordosis, and it was consistent for all ages. We found a statistically significant association between cervical pain and lordosis and a clinical normal range. So what they're saying is you've got a loss of cervical curve, you've got 18 times greater chance of having pain. That's a pretty big deal, isn't it? Now, we're not the only ones looking into this. You don't think the medical people are aware of this? They've got a different name for it. They call it cervical flexion myelopathy. So if you need a new diagnosis for your insurance companies, cervical flexion myelopathy. Previous studies have suggested that spinal cord compression by the vertebral bodies and intervertebral disc or neck flexion causes CFM. Same thing we're talking about here, where that neck is in a kyphosis. However, the exact pathophysiology of CFM is still unknown, and surgical treatment for CFM remains controversial. Yeah, they've tried to do it. Anybody here remember Alf Bragg? He wrote the book Adverse Mechanical Tension on the Central Nervous System. Fascinating book. And we're going to tie this together. But what he did is he had 12 patients that had MS. And what he did with them, he did surgery where he tethered the spinous processes together and induced a surgical lordosis into that neck. 11 out of 10 with MS went into remission. Interesting, huh? They couldn't look down anymore, but the MS symptoms were much better. So they call it cervical flexion myelopathy. Yeah, they're doing surgery. In all patients, axial MR-CTM demonstrated flattening of the spinal cord with posterior surface of the dura mater shifting anteriorly. So going back here again with that dura mater, as we go into kyphosis, we get a flattening of the spinal cord. There's that 30 to 40 pounds of pressure again. And then we start to see, because it's going into this, with the Chinese finger pull type of idea, that meninges is starting to pull and putting pressure on the back part of the spinal cord. The findings of this study suggest that degenerative changes of the dura mater may have a characteristic pathology of CFM. What's another name that's associated with the pathology for degenerative changes of the dura mater? How about degenerative changes of the meninges? Demyelination. MS, yeah. Nerve cell damage and whiplash. Changes in the inner volume of the cervical spinal canal during neck extension flexion motion causes transient pressure changes on the central nervous system, resulting in hydrodynamic effects that thereby mechanically loading the nerve roots and causing tissue damage. So what they're saying here in whiplash injuries, you know, there isn't air around the spinal cord, is there? It's all fluid, isn't it? As a matter of fact, it occupies about 1/3 of the space of the spinal canal, the spinal cord does, but all around it is fluids. There's a difference between, everybody understands hydraulics, right? If I go ahead and put pressure on fluid, it's going to react differently than compressing air. We have hydraulic pumps and things like this. So what they're really saying here, in a whiplash type injury, it changes a lot of things as far as putting this type of pressure directly on the brain and the spinal cord. Signs of cell membrane dysfunction were found in the nerve cell bodies of cervical spinal ganglia. Ganglion injuries may be responsible for soft tissue complaints. Abnormal spinal curvature's relation to pelvic organ prolapse. This is another article that I found in 2000. Now, this is going on beyond the cervical curve, but what this article is actually saying is looking at the lumbar curve, and what they found when compared with patients with normal curvature, patients with an abnormal lumbar curve were 3.2 times likely to have developed pelvic organ prolapse. So when there was a loss of the lumbar lordosis, there was a 3.2 times greater chance of having pelvic organ prolapse. This is in women, not in men, okay? Everybody understands what pelvic organ prolapse is? So everything starts to fall down in the pelvic area. You know how much it costs to get that fixed? $40,000 is the surgery to correct pelvic organ prolapse. You know how much it costs to get a lumbar lordosis back in the spine? Less than $40,000. All right. But again, it is important. Now, this one I really like, and I got this from Dan Murphy. He sent it to me. It's the use of flexion and extension MRI in evaluation of cervical spine trauma. What they did is they took 100 people that had been in car accidents and 100 people that had not been in car accidents and compared the two together. In the normal non-car accident group, only 4% had a hypolordosis, or a loss of cervical curve. Anybody here ever been in any type of a car accident? Oh, okay. All right. So you're not in the control group. Now, the author stated that hypolordosis is found to be present about 70% of the normal population uninjured, but in their study they found that only 4% of these ones that hadn't been in a car accident had a loss of curve. The trauma group, 98% had a loss of the cervical curve. Now, the next thing that they found is in the normal group, only 2% had disc herniations, but they were asymptomatic. Remember how even the AMA guides for whole body impairment basically say, and we see this a lot in court, yeah, disc herniations are normal part of the body, they can be asymptomatic. Well, there's a reason they're there. In the trauma group, 28% had disc herniations. So in no instance, this is their summation, in no instance was disc herniation and spinal stenosis observed in the absence of hypolordosis and segmental motion restriction. What Dan Murphy says, and he has a nice way of being able to put it in English, he said all patients with disc herniation and spinal stenosis had a hypolordosis. So if I want to correct a disc herniation, what do? Get the curve back. And guess what, people? It works. I've been doing this for the last 8 years with a lot of different patients. As we restore the normal curves to the cervical and lumbar spine, the disc herniations disappear. So if I go into a kyphotic neck, what are those discs going to do? They're going to go posterior, aren't they? Now, with all due respect, I know that decompression is the new big fad, and I think there's a value to it from a symptomatic point of view, but we're doing decompression, what are we doing? We're taking the curves out of the spine, aren't we? Now, going back to this Chinese finger pull, I'm going to show you in a couple minutes that the discs themselves have diagonal fibers. So as we pull those discs, what happens is it actually starts to bring it back into position. I've got a good friend of mine who's a doctor in Minnesota, and he's got the Lordex decompression. He's doing incredible things with it as long as he follows it with rehabilitation afterwards to get the normal curves in. I mean, his success rate is like 98%. With disc herniations. Now, I've got another friend of mine in California who doesn't do that, and 50% of his decompression patients drop out, and of those that continue, 50 to 75% have their problems come back afterwards. But if I think there's a value to it, and we can go ahead with our mechanical traction decompression, as long as we follow it up with rehabilitation to get the curves back. So when you start seeing those disc herniations, stop looking at the disc and look at the bones. right? What is normal as far as the spine goes? How can we get that normal function back in there? Spinal kyphosis causes demyelination and neuronal loss in the spinal cord. This is out of Spine in 2001. This is to evaluate the effects of chronic compression associated with kyphotic deformity of the cervical spine in the spinal cord. The spinal cord has a remarkable ability to resist chronic compression. However, delayed paralysis is sometimes seen following the development of spinal kyphosis. Talking primarily about the cervical spine. So when you go into a kyphosis, how many pounds of pressure can that put on the spinal cord? 30 to 40 pounds, right? In the past, no study was ever done to clarify this. There was a significant correlation between the kyphotic angle and the degree of spinal cord flattening. The worse the angle, the more the flattening. The spinal cord was compressed and most intensely at the apex of the kyphosis, which is what we'd expect, where demyelination of the anterior funiculus as well as neuronal loss and atrophy of the anterior horn cells were observed. Demyelination progressed as the kyphotic deformity became more severe, initially affecting the anterior funiculus and later extending to the lateral and then the posterior funiculus. Angiography revealed a decrease of the vascular distribution of the ventral side of the compressed spinal cord. Progressive kyphosis of the cervical spine resulted in demyelination of nerve fibers in the funiculi and neuronal loss in the anterior horn due to chronic compression of the spinal cord. These histological changes seem to be associated with both continuous mechanical compression and vascular changes in the spinal cord. So, what's demyelination? MS, yeah, and there's a lot of other things associated with it too. Think about it too when you start vaccinating these kids and adults and they already have abnormal tension directly on that meninges because of a loss of curve, and we know that vaccinations go directly to the meninges, don't they? How many kids get meningitis after vaccinations? A lot, all right? Ted Koren does a really good thing about this as well. Basically says that 50% of all kids that get vaccinated have some type of meningitis after the vaccination because it's an irritant to that entire system. Now this is another one that I really like because it's associated with scoliosis, but it's out of the European Spine Journal in 2001. It says a short, unforgiving spinal cord could produce the abnormal rotatory anatomy observed at the apex of scoliosis with first lordosis, then lateral deviation, and finally a rotation of the vertebral column with the rotation occurring between the the canal and the vertebral body around the axis of the cord. So what they're saying here, and it's kind of interesting, what we're saying here is when we lose the curves, the good curves in one dimension, the body's going to put them in another dimension, isn't it? That's where the scoliosis comes from. But because of this loss of cervical curve, the adverse mechanical tension on the spinal cord, Jay, stand up here. Okay, stand right here. Give me your left hand here. Now, if I want to take the spinal cord and pull it one way here, look what happens to his hips float and how it twists. The body's trying to get away and react to it. Now, if I get that cervical curve back in, look how it relaxes, it comes back to the normal position.
Don't want to pull my finger?
No, I don't want to pull your finger. Later. So what happens is when we start to see the loss of curves in the spine, the body starts to react to it. And there's a bunch of articles I've written on that very simply put, it's easier to go through the valley than over the hill. In other words, what happens is when I laterally flex to the right side, the spinuses should go to the right side as well in the upper thoracic. In scoliosis, they go to the left side, don't they? They go into the concavity. That's abnormal biomechanics because lateral flexion and rotation are a coupled motion. Now, why would innate allow that to happen? Because when it rotates off to the right side like this, it's going over the hill with the spinal cord. When the spinuses can rotate in the concavity like this, it's like going through the valley. As a matter of fact, when these spinuses rotate into that concavity, the ribs follow it, and that's where the rib hump comes from. So the only way to correct the rib hump is to correct that spinous rotation. Oh, I love this stuff. This is like fun. So we start to see how this short, unforgiving spinal cord can create problems. Now, it's really interesting because some of the articles I've been seeing lately is what they're saying is that the spinal canal, the bones in the body, are growing faster than the spinal cord, and that's what's causing scoliosis. But when we start to look at these kids, it isn't. The truth of the matter is they have kyphotic necks, S-curves in these necks. 95% of the kids with scoliosis had birth trauma. That's what I'm finding, okay? So we see really bad necks in them. But it really is, they're looking at it from a pathological point of view and trying to relate genetics to abnormal growth. All they got to do is get the normal curves back. Loss of the cervical curve will cause the spine to buckle. So we start to get this type of forward head posture. Now, when we look at the spine, and again, the way it is incredibly well made, we've got the cervical lordosis, thoracic kyphosis, lumbar lordosis. If we extend that all the way around, it's a circle, isn't it? That's what it should be looking like. Now, when you start to look at it from geometric points of view, there's a thing that's called remember the radius? Radius is from the center of the circle to the outside, right? A chord is a line that intersects a circle at 2 points. Now, if I have a cervical lordosis here that goes from C1 to T1, when the chord in this line, when all these 3 lines are equal, that's an equilateral triangle. It's 60 degrees, 60 degrees, 60 degrees. So that is the biomechanical structural stable point. When you start looking here, as far as these curves go, and then putting the chord in, we can start to see how these angles start to fit in the spine and why it was created this way. Here we're going back again to Alf Bragg. He wrote the book Adverse Mechanical Tension on the Central Nervous System. This is out of 1978. Now, here is a normal spine measuring the dura and inflection. See how the dura gets stretched and it constricts and pulls in there? This is actually pictures from a cadaver. Here's the spinal cord and the spinal nerve roots. See how the spinal nerves are kind of loose here? Inflection, see how they tighten up? So what happens is, if I'm a spinal cord, it could be a teapot too, let's say. All right. As I'm a spinal cord, we've got the dural sheaths that go around the spinal canal, don't we? So as I go into flexion, things tighten up, and then when I start to go off to one side, see how the dural sheath is going to tighten up and start putting pressure around that spinal nerve that comes out of there? You know, we get so hung up on, well, the hard bone has gone out of place and put pressure on the soft nerve. It's way more than that, and it's much more exciting than that. So we're starting to see this abnormal stretching there in those areas. So this is just a poster I put together. Normal curves, dural area, nerves, kyphosis, and then the stretching on that area there. This is a patient, these are some extras from a lady that was involved in a car accident in 1961. All right? Normal lordotic curve. Here she is in 1963. She's gone to a lordotic S-curve. Now, abnormal form causes abnormal function. So in this area down here, we're starting to see abnormal motion in regard to the disc. When I have a normal cervical lordosis like this, all the motion should happen here at C4, C5 disc interspace. That would be a pivot point or a stress vertebra. When we go into this type of neck, we start getting really abnormal motion. This area down here doesn't get the motion. Now those discs, after the age of puberty, require motion for osmosis and inhibition for normal disc metabolism, right? So that area is not starting to get it, so we start seeing a lack of motion. Lack of motion causes disc degeneration. Here's 1965. See the difference there? So this is 4 years after the car accident. Now, we can even get into, here's 1968. See how we're getting these bone spurs here? What happens, this area is under stress, so innate brings in calcium to make that area stronger. As a matter of fact, osteoarthritis is innate's normal response to trauma, because we're getting abnormal function here, so it's got to try and reinforce it and make it stronger. Here is 1970. See the changes down there? As a matter of fact, what actually happens is through piezoelectricity, pressure electricity, this area here starts to become extremely negative as far as the balance goes. And calcium is what? Positive or negative? Opposites attract, so body starts to bring in calcium to this area. How can you have a patient with osteoarthritis and osteoporosis at the same time? You've got too much and too little calcium, right? There's a dichotomy there, and yet we start to look at this and how these changes are. Here's 1972. Here's 1974. See the difference there? See how it starts to degenerate? See how getting that curve back is so important? Here's 1975. Actually getting quite a fusion in there from the way the whole thing changes. Now, I graduated from Palmer in 1974, so this wasn't my patient back in 1961. I'm not that old. As a matter of fact, I got these x-rays from a friend of mine, a student that I went to school with, and this is x-rays of his mother. And she'd been in a car accident in 1961, and the father was a chiropractor, and that's why we had such neat chronological x-rays going through this whole thing, watching it get worse and worse and worse. And I said, David, this is really good because now that you've graduated in '74 with me, you can go back home and get your mom fixed up again. Well, he went back home and found out that the mother and father had actually divorced. Well, after 14 years of bad chiropractic care, wouldn't you look for a new chiropractor? Watch this. Now watch as we start to go into a loss of lordosis here, and watch C0 and C1 and C2. Here we're getting more and more straighter. Now we start to see the disc compression. Look at C1 up here. Now it's going into a kyphosis. Now we're going to start to see, now watch C1 here as it starts to come down. We're starting to see the changes down here more. See how C1 is going more inferior with the posterior arch here. Look at the shifting down in this area here. C1 keeps coming down. See the degenerative changes in there? I was teaching a seminar on the Cayman Islands. One of the guys from ZBP gave me this. But what we're seeing here is there's a big relationship between the occiput and the atlas. All right. We can see these changes down here. We're going to be looking at this morning exactly how this atlas starts to function. As a matter of fact, as that atlas changes, as we go into kyphosis, the atlas starts to go more inferior with that posterior arch. And I want to show you how to correct that and what we're going to do with that. That's morphology, taking x-rays and then bringing them into a whole play, which is kind of cool. And I promised I'd give them a plug for CBP. Robin McKenzie is a physical therapist, and it's very interesting. He said 60% of back pain comes from what we do after we're done working and playing. Now, you've seen this in practice. It's like the woman goes out in the garden, she's working there all day long. She comes in and she goes and sits down in her lazy girl chair in kyphosis. She goes to get up. She goes, oh, my back is killing me. It must have been working in the garden. No, it was the position you got into afterwards that allowed the muscles to relax. The guy that's working on his car with his head in kyphosis, and he goes back into the kitchen, sits down and starts reading the newspaper. He goes to look at me and goes, oh, my neck is killing me. It must have been working on the car. No, it was a position they got into afterwards that allowed this to go out of position. If we start looking at what the normal curves are, and after activity put the normal curves back in, we're not going to run into problems, and especially if we start with good curves. This is out of Kapanji, Physiology of the Joints, Volume 3. It talks about the Dalmas Index. And quite simply it says when we take the actual length of the vertebral column from S1 to atlas divided by the fully extended column of S1 to atlas, there should be normal values. In English, all right. If we look at the way this spine is, okay, and if I measure S1 or C1 to S1 to atlas, and then I take that into a fully extended position. So let's say this measures 24 inches, this measures 26 inches. When I divide that and multiply it to times 100, there's a ratio which should be around 95. Now, if I take and lose those curves, I've got 26 for fully extended, 24 for normal curves, and now I've got 25. We're looking at here at 25, we actually have a static spine. It's not moving as much. If I go to too much curves, now instead of measuring 24, it's going to measure 23. This is too much of a dynamic spine. In other words, it's just like the timing on your car. The timing can be advanced or delayed, but there's one area where it's optimum, isn't it? Same way with that spine, there's one optimum area when the chord and the radius are equal, forming 60, 60, 60 degree angles. That's the optimum position. Now, Kapanji and both Sergei Gorbachev go through this as well. Sergei Gorbachev, anybody hear of him? He wrote the book called The Spinal Engine. Fascinating book. He says the spine is not a machine, it's not a bridge that connects the head to the hips. The spine is an engine that propels the body and makes it move. As a matter of fact, they had a young man that had no arms and no legs. and he was able to walk on his stumps. But when they put a cervical collar on him, he could hardly walk, had a real hard time. When they put a shoulder strap on him, he couldn't walk at all. Because when I move, it's that spine through my gait process that really locomotes and propels my body, doesn't it? So the spine is not a bridge that connects the head to the hips. It's an engine that propels the body. If you have a bridge that's starting to break, what you have to do is patch it, right? Okay? This is why surgery doesn't work when it comes to the spine. Let's say you've got a car with 6 cylinders and the car's not running right. If you fuse 4 of the cylinders together, is the car going to run better? Duh! Hello? Big red truck, right? All right. Blonde calls up the fire department. She says, come over quick, my house is on fire. The fire chief goes, how do we get there? She goes, duh, big red truck. I love that joke because sometimes the answer is so obvious we miss it, don't we? Okay? It's like, yeah, hello, if it's an engine, you don't fuse those cylinders together. You don't fuse the vertebra together and expect it to run better. So, Thone's catastrophe theory came out of Scientific American in 1973, and this is good for a lay lecture for your patients. As a matter of fact, when we're born, Renaissance at one time said 80% of the kids born in a hospital have some type of birth trauma. All right? 80% of home deliveries probably don't. So there can be trauma there. And then they get in that typical fall on the ice, all right? And then they, 16 years old, you run into a tree, not sure what's going on. No big deal, Dad. My neck doesn't hurt, it's just the car. Then they get up one morning and they bend over to pick up something and all of a sudden their back goes out. Okay? They don't like that. And now it's just kind of like Humpty Dumpty. Come on. Okay, remember all the king's horses and all the king's men? Now people are down here in their pain and they're going, I don't want pain. Pain is not a good thing, and I agree, I don't like pain as well. But everybody wants to go from 6 up to 5 instantly, don't they? Okay? So what we'll do is do a little bit of icing, do some adjustments, some spinal molding, blocking. All of a sudden they're here at 5 and they're going, well, man, chiropractic is fantastic. Doc, you're the greatest person ever. All right? But they're walking on the cusp, aren't they? They're right there at 5, and the next time they bend over, their back's going to go out. It's like the guy that says, yeah, I go see a chiropractor 3 or 4 times a year when my back goes out. That's it, okay? They're walking here on the cusp. As chiropractors, is it our job to get this patient from 6 back up to 5, or is it our job to take them all the way back to 1? This is the difference between a chiropractic aspirin and chiropractic rehabilitative care. Do we want them walking on the cusp, okay? When I was 16, I had shingles, I got adjusted, they were gone. When I was 17, I had mono, I got adjusted, 3 days later the mono was gone. In the last 34 years in practice, I've never had a sick day, I've never had a cold, a flu, or a headache, okay? Chiropractic works, people. It really does. But again, it's the chiropractor that doesn't always work. So really, our job is to get them not just from 6 to 5, but 6 all the way back to 1. When we think of a catastrophe, we think of like a hurricane. That's a bad thing that happens. But if you look in the definition of catastrophe in the dictionary, catastrophe is defined as any sudden change. So when I'm standing here at 5 and I go down to 6 into pain, that's a catastrophe. That's where Thone came up with the catastrophic model of this. So really, we don't want to be here. We want to be all the way back to 1. Now, engineers tell us that the number of curves squared plus 1 equals resistance. So in the developing baby, we have the fetal curve, right? 1 squared is what? What's 1 times 1? 1 plus 1 is 2. So right here, when we look at that, even with the fetal curve, there's a mechanical advantage to it, isn't there? It's kind of like they used to use a crank to start the Model T cars. They didn't use a screwdriver because curves have mechanical advantages. Remember the 6 different types of simple machines? Incline plate, wedges, pulleys, things like that, okay? So remember the teeter-totter you're on when you were a kid? So the curves give a mechanical advantage, and the baby's developing inside of the mother right now, and sometimes these mothers aren't they have balance failures. They bump into things, but the baby has that curve, so everything is working fine. It can resist some of those traumas. The next thing that happens, though, is the baby's born and comes out. Now, poor Josh, he's my son. As I said, he's at Parker College right now. And he wasn't even going to become a chiropractor until he got into this whole thing with scoliosis. But as a baby, I would hold him up and watch his head drop down. Okay? So then I started playing with them. You know, what happens, they have to develop that cervical lordosis to hold their head up, don't they? So I would take him and hold him like this, and he'd bring his head up and look at me, developing the extensor muscles to bring the curve back in his neck. Poor kid. He's got trauma. It's going to take years of psychotherapy, I'm sure. It's like any chiropractor's kid. Now we have 2 squared. 2 plus 2 is 2 times 2 is 4, plus 1 is 5. See, now we've got this type of mechanical advantage. Now the next thing that happens is inherently as we get the cervical curve in here, we get a third lever arm that goes from the center of the head, which is where the sella turcica is, back to the atlas. So now we have 1, 2, 3 curves. 3 squared is 9, plus 1 is 10. The next thing that has to happen is the crawling. Remember that old adage, you have to crawl before you can walk? So as they start to crawl, they develop the lumbar lordosis. Now we have 1, 2, 3, 4, 5 curves. 5 squared is 25, plus 1 is 26. So now it's 13 times stronger than it was at birth, or 26 times stronger than it was perfectly straight. Remember, the curves of the spine give it strength and flexibility. Do you think the curves are kind of important now? All right. So we got to have those curves back in there. But then what happens is we start going off to school and we sit in these bad chairs, you know. It's like you get up in the morning, you sit down to eat breakfast, and you drive to work, you sit in a chair. 80% of the people have sedentary jobs, so they're sitting like this. They get in the car and they drive home, lie down in their lazy boy chair and watch television, go upstairs, go to the bathroom, go back downstairs, watch some more TV, and crawl into bed. As a matter of fact, most of them are then sleeping with a couple pillows like this in their neck all night long, and they go, oh, I wonder why I feel so terrible when I wake up. Have you seen where sleeping problems is actually, insomnia is like epidemic right now? That's because nobody knows how to prepare the spine for sleep. Developing the curves is really important, and then they're doing really good. Now, going back, we're going to start looking at this cervical spine and how to figure this whole thing out. But if you look at the white line and the green line, this is actually 60, 60, 60 degree angle. All right. When we start to look at the spine itself, I want to go to the ADP first. This is the center of mass to the atlas, okay? And if I draw vector lines there, here's a 60 degree angle, 60 degree angle, 60 degree angle. These vector lines then come through the lateral mass, which is a wedge, isn't it? The lateral mass isn't a flat block, it's like a wedge. So the angle of incidence is equal to the angle of reflection. So then the vector lines are diverted down here to the thoracic spine, 60, 60, 60. The sacrum itself is a wedge, 60, 60, 60. So these lines are coming up here, 60, 60, 60. Now when we look at it from the side, here, the way that the head is coming down, okay, and related to gravity, if I look at from one side to the other side, turn it around, again, 60, 60, 60, 60, 60, 60, 60, 60. Now, we have to relate to gravity, don't we? That's pretty much a constant unless you're scuba diving, in utero, or out in outer space. When gravity comes down, then it's actually the gravitational weight line splits the equilateral triangle into a right angle, which is 30 degrees, 60 degrees, 90 degrees. The sine of 30 degrees, according to trig, is 0.5. So half the weight goes down one side, half the weight goes down the other side. Do you see how important this equilateral triangle is? 60, 60, 60, split by gravity. Now it's 30, 60, 90. When we look at it from the side here, we've got a 30 degree angle here, 60 here, 90 here. Half the weight should go in front of the gravitational weight line, half the weight should go in back. Now, again, I've got this 30, 60, 90 fetish, all right? It's not a bad one to have compared to others. But we start to look at this, we start to see that the annular fibers of the disc are all at 30 degree angles. As a matter of fact, the dura mater that we talked about, 30 degree angles, kind of like a Chinese finger pull. It has this type of mechanism in it, but that's 30 degrees. When we look at, when you look at an X-ray on a baby, the vertebrae are kind of like block vertebrae, aren't they? Rectangular. As we get older, we start to get this indentation here, don't we? The insides start to curve in. And what happens here is because of this piezoelectricity that we talked about and Wolff's law, remember Wolff's law? Where bone goes through remodeling and we start to look at this, it's actually the chord, the radius equal, again, 30, 60, 90 degree angles. So there is a geometric beauty to this spine that is just completely amazing. As a matter of fact, this is where all engineering stuff comes from. Okay? Fortunately, we know about the master engineer. When we start to look at bridges, all equilateral triangles, 30, 60, 90. Okay? What engineers want to do is to use the least amount of materials at the cheapest cost to make the strongest thing, don't they? If we look at this bridge here, how many see a bridge? How many see a cervical lordosis? All right. But just the way that bridge is suspended. This is actually over in France. It's one of the old arches. It's like 3,000 years old. But remember the old Roman arch? The square ones didn't stay up. They collapsed. What is the oldest equilateral triangle in Europe, in Egypt? Pyramids, yeah. They're equilateral triangles. They're actually called tetrahedrons. When we start looking at tetrahedrons, which is 60, 60, 60, 60 degree angles, we find out that the carbon atom is a tetrahedron. Carbon is the basic building block of life, isn't it? As a matter of fact, diamonds are tetrahedrons. Silicone chips are tetrahedrons. So we start to look at these angles from a geometric point of view, and this kind of got me. Michelin was coming up with a new tire, and it's not an inflatable tire. These are actually 30, 60, 90 degree angles here. Can you imagine have a car like that? Wouldn't that be cool? So I got to get a new set of tires. And they actually say that when it hits these things, it'll never break or deform because of the geometric perfection of the equilateral triangle. It is the strongest structure in the universe. All right? This is just a real simple building, but look, 30 degrees, 60 degrees, 90, here's a Roman arch, even these little tile coverings here. This is a culvert by my house. Why is not the culvert square? Because 30, 60, 90, all right. This is a bridge, and it's a little off angle, but again, 60, 60, 60, 30, 60, 90. When I was in college, I used to paint bridges, so I got another bridge thing going on here. 60, I spent a lot of time underneath bridges looking at all these equilateral triangles. 60, 60, 60. This is the bridge just below Niagara Falls, okay? Now, you see a bridge there, I see a lordosis, okay? But again, the same geometric terminology, the same geometric terms. The Hoover Dam is actually curved, isn't it? It's not a straight dam. Why did they curve that dam? Because of the force coming in as far as the pressure goes. When it's curved, it's going to be able to resist that water much better. So as the dam is like this, the water's pushing here, isn't it? Now, the other thing that's very interesting about, anybody go scuba diving? As you go deeper, what happens? More pressure. And when you look at the Hoover Dam, it's actually thicker on the bottom than it is on the top, 30 degrees, 60 degrees, 90 degrees, because there's more pressure on the bottom. So the same geometric terminology that applies to bridges and dams also works with the spine. This is the San Francisco Bridge. Margie is my office manager. She's been with me for over 30 years. Not that she's weird too, but when she goes on vacation, she comes back home and she takes pictures on vacation of 30, 60, 90 degree angles from me and brings them back. So when she was in San Francisco, she went underneath the bridge and took a picture of it. St. Louis Arch. Now when you look at it, it's kind of deceiving, but actually 60 degrees, 60 degrees, 60 degrees. Split by gravity, 30, 60, 90 again. Eiffel Tower in Paris. I don't know if anybody's been there. I spoke at the chiropractic college over there a couple years ago. But there's a whole plaque on the bottom of the Eiffel Tower talking about the 30, 60, 90 degree angles and how important they are to the structure of that. So, see how there's a geometric precision to the spine that goes along with engineering principles. And again, going back with the normal curves. Now, jumping here, we know that posture is the window to the spine, isn't it? This is peanuts. This is my depressed stance. When you're depressed, it makes a lot of difference how you stand. The worst thing you can do is straighten up and hold your head high, because then you'll start to feel better. If you're going to get any joy out of being depressed, you got to stand like this. Okay. Callier says with forward head posture, normal lordosis of the neck and the back is lost. So there's a correlation between forward head posture and the loss of lordosis. So we've got to be able to measure forward head posture. The head is the most neglected part of the body. It's an axiom that the head follows the body. Wherever I put Jay's head, his body will follow. All right? Maybe because the brain's up there too with the writing reflex. You can realign the entire body by moving your head. It's more important than the shoulders and the feet. When we start to look at this, what we really see is that the gravitational weight line should be at the anterior aspect of the cellateristica running through the anterior 25% disc space of C4, C5. As a matter of fact, Callier talks about this in his book, both soft tissue disability and neck and arm pain, Soft tissue disability, page 66, neck and arm pain, page 16. But he said for every 1 inch of forward head posture, it increases the apparent head weight by 10 pounds. So as the head moves forwards, it actually feels like it weighs more. All right, my turn to pick on you. Morning.
Good morning.
Stand up here. This is what we do with the patients. We'll show them the x-rays now. This is only a 6-pound shot put because it's a lot to carry in my luggage when I fly. And they have weight restrictions. Hold it there. It feels like it weighs 6 pounds. Okay, now hold it out here. Is it heavier?
Yes.
No, it still weighs 6 pounds. It's magic, and you're stupid. All right, I'm sorry.
He's holding the ball.
Yeah, but because you've increased that lever arm here, this is how it starts to change. So then I'll say, okay, you know, when you stand like this, your head should weigh 10 pounds. The way you stand, it feels like it weighs 16 pounds. Then I'll drop that around on their head, see what it feels like to weigh 6 pounds more. So we give them this idea as far as leverage goes. Now the next thing, turn around this way, hold it right there. Now turn your hand upside down. Nope, yeah. Okay, yeah, go ahead up there. Keep that curve. Feel how your elbow wants to come out to the side like this. In other words, because we've got the forward head posture, when we lose the lever arm in one dimension, the body starts to put in another dimension. Now this correlates with scoliosis or any type of subluxation in the spine. If this spine goes forward and deviates laterally off to the side, and this is why bracing doesn't work with scoliosis, by the way, because they're trying to push this curve here and the head's hanging out here, so as soon as they take the brace off, it goes back out again. But by reducing the forward head posture, see how it's much easier now to bring this lever arm in? All goes back to biomechanical principles. So we start to see how that starts to change as far as having that head out there. And as the head goes out, what happens? The body has to compensate and lose the curve. I actually went out and got a bowling ball and bought it. And they said, well, do you want this drilled? And I said, no, because I don't want to go bowling. I just want a 10-pound bowling ball. And then I came up, after going to the state fair, I came back and to the guy and I said, I want one hole drilled in my bowling ball. The guy knows I'm a chiropractor. He knows I'm a little weird. So he drilled one hole for me. So I put my bowling ball on a stick, because that's what they have at the state fair. Okay, in Minnesota. So we show patients how this little bit of a deviation can start to change things. Now, this kind of goes into like a C0 atlas, occiput atlas. This is a stable position in extension. This is unstable in flexion. And that's going to correlate with some of this stuff. And this all kind of goes off to the side. Sheely said that forward head posture causes back pain, headaches, and depression. Affects everything from breathing to emphysema. Freeman found out that forward head posture resulted in intestinal problems, hemorrhoids, varicose veins,
and good deformities, poor health, decreased quality of life, and shortened lifespan. Len states observation of forward head posture affects every physiological thing in the body, causing spinal pain, headache, fluid, blood pressure, pulse, lung capacity, and moving functions that have to be changed. So in other words, we've also got to be able to change that forward head posture. What happens as we lose the curve, the head goes forward, doesn't it? Now, this could be a chicken or egg thing. We've got to get both of those things back in their place. This is real interesting, and this is a paper that was published back in 1996 by Harlan and Yoakum, What they said is almost immediate physiological change, the effects of change in length of the bones.
In their study, they put a 9/16 inch pad under a foot, and in 2 weeks, MRIs revealed numerous areas of increased marrow signals indicating bone marrow changes. So what they did is they purposely made this person unbalanced by just about a ½ inch. Within 2 weeks, there were piezoelectric electromagnetic changes going on in the body to actually begin to see bone changes in that body. So see why balance is so important, even this forward head posture. I had one kid that came in to see me. He wanted to join the Army, and he had flat feet. And I said, well, that's coming from your head. He said, what do you mean? I said, with your forward head posture, as you go forward, your arches flatten out. As you come back, the arches come back. So we worked on him for 4 weeks, and after the 5th week, he was able to get back into the Army. Forward head posture causes flat feet. Now, the spine has coupled motions. Lateral flexion, rotation are a coupled motion. When we look at this, we start to see, and normally, in this top picture here, we're going to have a low shoulder and a high hip on the same side, aren't we? That's normal posture, or a high shoulder and a low hip on the same side. What's interesting, in kids with scoliosis, they have a high shoulder and a high hip on the same side. So again, there's abnormal coupled motions that are going along with that. Gray's Anatomy says the cervical spine should have a lordotic curve. And what does Sherman College say? Anything innate wants, right? Sorry. Anybody graduate from Sherman? It's a good school. Back in '74, I took the Wisconsin State Board, and one of the questions was, is a kyphotic neck a subluxation? True or false? Yes or no? Now, what's the definition of a subluxation? Depends where you went to school, right? Loss of juxtaposition of the vertebra, right? Occludes an opening, possibly from a meningeal stretch. So anyway, I marked it yes because that's what I felt, and I passed the test, but still not sure what they wanted. Back in 2003, I did a research project, and this kind of goes into, Kim Christensen did a thing, specific applied adaptation of imposed demands, said, the human body would predictably change in response to demands placed on it. So what I did is I started playing with these head weights. Okay, let's get into this. And this is something that Pettibone and Harrison have been working with. Pettibone probably started out with it. By putting a head weight on the patient, the idea is that by putting the weight in the front, it's almost like a type of homeopathy. It makes the muscles work in back. So it brings the neck into extension. Then with the righting reflexes of the eyes, it should balance the head out and decrease the forward head posture and improve the cervical lordosis. So we actually did a study with that. We had 131 people, and we had to put a head weight on them for 5 minutes and had them on this wobble chair to loosen things up. We took an x-ray before, and then we took an x-ray after 5 minutes with the head weight on, and actually found that we had average improvement in cervical lordosis was 34%, and forward head posture was reduced by 18 millimeters. So these are just some of the x-rays. This is with a normal x-ray, and this is with the head weight on. You can see the improvement of the cervical curve, decreased forward head posture. Okay. So this was 5 years ago we started kind of playing with this, and it was published. Okay. Now, one of them actually got worse because there was too much weight on it, it buckled. We've got to be able to use the proper amount of weight doing that. Average head posture reduced 0.62 inches, which is actually pretty good. And this is out of JSVR. You can still find it in there. Lord Kelvin said, when you can measure what you are talking about, when you can express it in numbers, you know something about it. But if you cannot measure it, if you cannot express it in numbers, your knowledge is of a meager and unsatisfactory kind. It may be the beginning of knowledge, but you have scarcely in your thoughts advanced to the stage of a science. So we want to be able to measure what we're doing. Dr. Tony, there you are. One thing that's real important is making sure that your x-ray is in proper alignment. Okay, that your x-ray machine is, and there's ways to do that. There's an alignment block that we use, and we'll get into that a little bit more detail. Now here's reasons to x-ray: anthropometric spinal analysis, putting numbers on x-rays, verify the radiologic component of the vertebral subluxation complex, calculate abnormal spinal biomechanics through x-ray analysis, verify static spinal positioning, confirm your diagnosis, evaluate for osseous chiropractic adjustments, assess soft tissue injuries, especially ligamentous, evaluate permanent impairment and disability, evaluate degenerative changes, rule out joint instability, fractures and anomalies, rule out underlying disease processes, and prepare for a treatment plan. Reasons to re-x-ray. Insurance companies don't like to pay for post-x-rays, do they? Verify reduction and stabilization of the vertebral subluxation complex. Again, your anthropometric analysis. Are my measurements changing? Monitor and evaluate the effects of spinal adjustments. What are my adjustments doing? Back in Palmer in the early 70s, we'd go and toggle a patient and go, wow, I wonder what that did. Yeah, you know, it's like, we just walked away. Determine spinal instability and stability, determine if proper joint motion is reestablished, monitor degenerative changes, evaluate permanent impairment disability, biomechanical spinal evaluation to determine the effectiveness of our treatment plan, lack of progress or increase of symptoms, determine the effectiveness of treatment, new symptoms, and new injury. Now, from an insurance point of view, they really don't care about any of these except for three. One, if there are new symptoms, that's a reason to x-ray. 2, if there's a new injury, that's another reason to re-x-ray. The third, and this is the most important one, and if you do this in your notes, you will get paid for your post-x-rays 100% of the time, is to evaluate permanent disability. I am ordering a cervical dorsal nasium X-ray to evaluate permanency, impairment, and progress, is how I put it. In other words, as long as you put those words in there, we are doing this to evaluate permanency and impairment, the insurance companies will pay for that X-ray without any problem. Because what they're doing is look at a monitoring, is there a permanent problem from this condition? Now, let's say I do a evaluation on a patient. Let's take it real simple. Let's say the patient goes in for a cholesterol blood test, okay, and the cholesterol is way off the charts. They take their medication, they go back a year later, they take the blood test again, and the blood test is normal. Does the insurance company pay for the normal blood test? Sure they do, okay? Same way, I can evaluate permanency, impairment, and progress with a post-X-ray, and even though there may be no permanency, the insurance company will still pay for it because it's a diagnostic value. So, looking at the X-rays, lateral cervical X-ray is taken at 60 inches. By doing 60 inches, we get our object focal film distance at 6 inches, what it comes down to. So we get bilateral magnification. So I want the center ray going directly through the atlas. And the first thing we're going to look at the X-ray is the eye plane line. Now, if you go back here, you can't quite see it, but I've got a mirror right here. So when I take this X-ray, I have the patient, and these are done in a sitting position, by the way, because it puts more stress on the spine. But I want that patient looking straight at himself in the mirror, because I don't want flexion X-rays or extension X-rays yet. So we're going to have him looking straight ahead and in the mirror. And the way I can verify this is the eye line straight? In other words, is the sella turcica, which is this part here, going through the eye? So we just want to make sure that they're in a neutral position. I don't have to put that line on there. Now the next line we're going to put on is the skull base line. I want to be able to relate the head to the rest of the neck. So what I'm going to do is put a dot 1/2 inch posterior to the mastoid right here, and I'm going to put another dot right in the zygapophyseal notch, which is right here. Now, most of you can't see that on an X-ray, but if you think about it, if I turn the X-ray upside down, and if I were to drop a BB in here, the BB is going to land right where that parazygapophyseal notch is. I like that. Cool, huh? That was an airplane thing I figured out yesterday. If it wasn't for airplane rides, I'd never get anything done. Anyway, so that's the skull baseline. Now the atlas plane line goes through the center of the posterior arch. What is also in the center of the posterior arch of the atlas? Spinal canal, spinal cord, a dot on the anterior tubercle. By connecting those two lines, okay, then I've got an atlas plane lines. Now normally those two lines should be parallel. They really need to be parallel. So we can actually measure it if they're not parallel, okay. We'll look at this a little bit more. Oh, here's another. So going back, here we can see there's an extension malposition. This was actually done by one of the students. Another reason why it's important, would you X-ray a 3-month-old baby? Now remember, going back here, these two lines should be parallel. Atlas line, skull base line. Sudden infant death syndrome kills approximately 6,000 babies every year. I was doing some research in scoliosis and came across this, and I found it was really interesting. And there's an article I wrote, you can find this on the CLEAR website, in a study of, okay, let me go to the big one. This is out of 1979. A guy by the name of McGillis found that 10 out of 11 babies that had died from SIDS had an inversion of C1, which is an extension malposition, where the skull base and the atlas plane line come together posteriorly. So this is in 1979, and it turned out the 11th one had severe alar ligament damage. What they do is they'll X-ray these babies after they die for the autopsy. Now this really blew me away. In 1991, Schneider did flexion and extension X-rays on 50 babies who had died from SIDS. He found out that all of them, 50 out of 50, had an atlas inversion, which is an extension malposition of the occiput on the atlas. This is out of the Journal of Chiropractic Research. Both these guys were chiropractors. Haven't even heard of this research, have you? So sudden infant death syndrome related to that. Now, I've got a chiropractor friend, Dr. Scott Sorum, who's in Seattle, Washington. His wife works for a coroner's office. And I said, could you send me some X-rays of babies that had died from SIDS? She said, sure. So these are 3 babies that had died from SIDS. Here's the atlas plane line, here's the skull base line. This is 14 degrees, this is 16 degrees, and this is 14 degrees. Now, if you think about it, we know that stimulation of that suboccipital area will cause breathing problems. So we go ahead, we've got an extension malposition. You then turn the head, put the baby on the stomach and turn the head to the side. What's that going to do to this C0, C1 area? It's really going to jam it up, isn't it? So again, I've got an article that I wrote on this at the CLEAR website. You can look in that further detail. And then, how many of you still have your speeder from chiropractic college? What I did is I took the speeder and put a little L-frame on here and some surgical tubing and made a little bit negative Z baby adjuster. Okay? And I had a kid that came in, this is 4 or 5 years ago, he was about 4 months old, and he had stopped breathing 3 times. So the mother was freaking out, and she brought him in. We did this adjustment on him, which is a negative Z, and he's now 7 years old, and he hasn't had any problems since. So this was a long time ago. So there definitely is something along with this. And this is my grandson, Elijah. I took an x-ray on him at the age of 2 months. I wanted to see where C0 and C1 was. They're parallel. All right, this is a whole other thing. But there is important to that. Now, the next thing starts coming along then. What is the normal relationship of the occiput to the atlas? How many of you have gone through any of the Pettibon stuff or heard him speak? Pettibon, when I used to teach with him, said that 98% of the patients had an extension malposition of C0 and C1. Okay? In other words, the skull baseline, atlas plane line converge in the posterior aspect. So I started looking at that, and I actually talked to Dr. Ray Wiegand, who worked with Dr. Pettibon at that time, and he said, no, that's not really what happens, because there wasn't any research on it. He said, really, what happens is 88% of the time there's an extension malposition of the occiput on the atlas, but 68% of the time the atlas has gone inferior on that same side. So only 20% of the patients have a true extension malposition of the occiput on top of the atlas, which means when we do this negative Z adjustment, the x-rays wouldn't change because we were pushing the occiput back up and it dropped right down again. So I started looking at this, and I started looking at Grostic, Nuka, Pettibon, CBP. None of the techniques had ever measured the relationship of the atlas to the axis in the lateral dimension. Is a subluxation three-dimensional? Well, so yeah, it is, but we only approach it usually one dimension at the most. Now, if I had a patient that had a 9-degree lower angle here, this would be a really big deal, wouldn't it? But this is the atlas plane line, this is the superior stress line. If I had 9 degrees of rotation on a base posterior film, that would be a really big deal, wouldn't it? That's a lot of rotation. And yet, when we start to look at this area here with the skull baseline, those two lines should be parallel. If the atlas drops inferior, that can be a really big deal. And this happens with a lot of people, a lot of your patients. And when that atlas goes inferior, then the skull goes anterior, forward head posture, and we lose the cervical curve. So you get that? When the atlas drops inferior, it increases forward head posture, which causes more of a loss of cervical lordosis. To correct the cervical lordosis, we've got to correct an inferior atlas. And I'm talking about the posterior arch. Now, going through research, there's a guy by the name of Freeman that had done 25,000 digital X-ray analysis. He found that the normal curve, the normal position of the atlas should be 18 degrees. If I measure off from a perpendicular line from the skull or the atlas, so it'd be 18 degrees here or 72 degrees on this side here. So after talking with Ray Wiegand, I really started to realize that the atlas has dropped inferior 68% of the time in people, and this is a subluxation we haven't been addressing, which is why I've been having problems. Now, as the atlas drops inferior, the skull drops down on top of the atlas, doesn't it? So really, the C0, C1 extension malposition is compensation for this atlas being dropped inferior. It kind of drops down into the cusp. So what we try to do is push this skull back up, and the patient comes up to gravity and drops right back down again. Or if we take the atlas and just adjust it inferior to superior, it corrects that inferior atlas, corrects the forward head posture, and allows the skull and the atlas to come back into a normal relationship. Only 20% of the patients have a true extension malposition, not the 98.7% of anecdotal research that was done on it. So looking at it here then, we should have an 18-degree angle between the perpendicular. If I put a protractor on here, okay, this would be 18 degrees on this side, so you have to come down from the 90 and measure over, or 72 degrees on that side. That's the normal relationship of the atlas to the cervical spine in the lateral dimension, which is really important. Now that's part we looked at. Now we can see here this has actually become larger than 18 degrees. So let's say it's 20 degrees. See how the atlas goes inferior? And if it's less, then the atlas has gone superior. So here's normal, inferior, superior. Whoop. See how that atlas is going to move? So being able to understand that makes a really big difference. Now the other thing is we have to look at this whole thing dynamically. What happens in normal motion? When we go into extension, each vertebra moves 7.5 degrees. So as I go into extension, the atlas angle should actually, it starts at 18, so the atlas angle should increase to 25 degrees. The occiput angle relative to that line should then go to 33 degrees. Because 15 plus 7.5 degrees is 25.5. Okay, so this should go to 25.5. Plus 7.5 is 33. That's normal motion as I go into extension. Watching those three functional units. When I go into flexion, it should decrease by 7.5 degrees. So as the atlas moves 7.5 degrees from 18, it goes down to 10.5 degrees. As the occiput moves an additional 7.5 degrees on top of that, 7.5 degrees on top of the 10.5 degrees, it should go to 3 degrees. So being able to look at cervical flexion and extension x-rays, I start to see how this whole thing is functioning. But this is something that we've been missing chiropractically, and now that we found it, the doctors that we've been doing this are seeing just dramatic results, not just symptomatically, but structurally as well at the same time. So being able to measure that. Now when it's inferior, we need the posterior arch has gone inferior, so I'm naming it from the way that I want it to go. So we go inferior to superior with the adjustment. If the occiput has gone inferior, we'd adjust it inferior to superior. If they've both gone inferior, we'd have to adjust each one. And you can tell this by looking at those x-rays in flexion and extension. So here's the 18-degree angle. Here it is greater than 18 degrees is an inferior atlas, less than 18 degrees is a superior atlas. And again, the majority, 68%, are inferior atlases. So this is how we'd have to adjust those. If it's, okay, here's inferior, and this is a flexion malposition. If it's superior, you just come with a superior line of drive. And I use the arthrostim for most of my cervical adjusting, using a double prong on it. We'll show you how to do that in a minute. Josh came home during Christmas, and we took an x-ray. He was 30 degrees and 29 degrees. So what is normal here? 18 degrees. So how many degrees of subluxation did he have? 18 minus 29 is 11, right? That's a lot, isn't it? So, and the skull had dropped down on top. So all I did is I come in with the arthrostim and adjusted this from inferior to superior. That was the only adjustment I made. Then I posted him. He went from 30 to 22 and 29 to 23. But see how that occiput had compensated to the atlas? Before, I would have done the negative Z on him to push that occiput back up, and it would have dropped right back down. And he's had some pretty dramatic changes since then. But I just wanted to see exactly what we're doing with that adjustment. Going back to the analysis, when we look at the disc height in the cervical spine, it should be a 2:5 ratio. In other words, the disc height should be 40% of the vertebral body height. So you can actually measure that. You know, we know that disc thinning becomes spinal degeneration, doesn't it? As far as the degeneration theory. So in the cervical spine, it should be a 2:5 ratio. Just FYI, thoracic spine should be a 1:5 ratio, lumbar spine should be a 1:3 ratio. Now, we talked about forward head posture, being able to measure that. What we need to do, this is the sella turcica, and we'll see that on the x-ray in a little bit. We need to draw a line straight down, and that should come through the anterior quarter of C4, C5 disc interspace. Right there is where that line should cross. Now, he said for every inch, it increases the apparent head weight by 10 pounds. So if I measure from the anterior 25% of the disc out, and it's out 0.5 inches, what is the apparent head weight? How much does that patient feel like their head weighs? 15 pounds. And what's the actual increase? 5 pounds, right? So if this was out 1 inch, what would the apparent head weight be? 20 pounds. 2 inches, 30 pounds. 3 inches, 40 pounds. So we can see how we can actually start to measure that. This is the superior stress line. It's drawn along the back of the body of C2. Now that's the line that I put up to measure to the skull base line and the atlas plane line. So we just put a dot on the top and the bottom of C2 on the posterior aspect. That's the superior stress line. We do the same thing on C7. put it down to the superior and inferior posterior aspects of C2 and draw that line. Now where those two lines cross, that should be the stress vertebra. Normally a C4, C5 disc interspace, and there's a reason for that as well. When I look at this normal cervical curve at C4, C5 disc interspace is where the cervical bulge is at. In other words, that's where the nerves are the largest. And yet also at C4, C5 disc interspace is where the holes are the smallest. The spinal canal is smaller in that area. And I'm going, man, innate blew it here, didn't he? She. Innate just screwed this up royally because we got big nerves and small holes, which doesn't make any sense until you realize it's a pivot point. If I have a teeter-totter, one side goes down, one side goes up, what happens at the fulcrum point? What type of motion is there? There's no motion, is there? So when I go back to a normal lordosis, I go, yeah, there's no motion, so the big nerve, small holes actually make sense. But if that stress vertebra changes, and let's say if C, instead of being C4 or C5, it's down here at C6. Yeah, doc, it's really funny. I turn my head to the right and I get a shooting pain down my right hand. I turn my head to the left and my left arm goes numb. There's a reason why that optimum curve is there. So we can actually measure that curve. Now, because of the way we're using C1 and C7, 45-degree curve is normal. If I were to use the occiput and T1, it would be a 60-degree curve. So there's actually a chart we go back and we look at. 38 degrees is a 16% loss of curve, so we relate that. Now we're going to go back to our Gonstead lines. Remember the vertebral body baselines? We're going to draw those lines going out on the bottom of each vertebral body. Now, theoretically, all those lines should converge at 6 inches, so they should all come together in a normal lordotic curve. What happens is when this line diverges, this vertebra here has gone posterior or backwards. Now again, when I was at chiropractic college, which was a long time ago, I was taught that what happens is the vertebra slips down to the zygapophyseal joint and then the lines come down. Well, that's if we look at a dry specimen. If you think about it biomechanically, I've got this head weight hanging out in front here, don't I? It's like a cantilever, okay? Because the center mass of the head is in front, so as this pressure pushes down in front, see how the vertebra go posterior and go backwards? So when the lines diverge, it's a posterior vertebra. And they should all be converging in that area. So I'll figure out which vertebrae aren't coming together. For example, C3, C5, C6, and C7, the lines aren't coming together. Those are the ones I want to actually adjust from posterior to anterior. We can actually measure C2. That should be an 82 to 90 degree angle. So this is the lateral cervical analysis. We've got the skull baseline, the atlas plane line, superior stress line, inferior stress line, vertebral body baselines, and the apparent head weight line. I'm going to run through this fairly quickly because we're running out of time. And we're going to have these notes in the videotape of this all available as well. Flexion and extension x-rays really help us to understand that spine dynamically. And there's a lot of different reasons to do it, which we verified as well. So we just have the patient look up, and when we see this, we put the exact same lines on here, okay? And when I do that, we look for kind of slippage, a loss of motion, segment integrity, the ligament damage. A normal extension angle with C2 and C7 should be 70 degrees. Flexion is 60 degrees, which gives us a total 130 degrees of motion in that area. We put our same vertebral body baseline, so I know here that C3 is restricted in extension. When I go into extension, that vertebra is not working properly. So we do the same thing in flexion, same lines. Okay? We won't get into the AMA guides. In flexion, this should be a 60-degree angle, and all those lines should diverge when I go into extension, or go into flexion, sorry. Now, there's a time when both lines don't cross. That means we've got a double curve. There's a lordosis here and a kyphosis in the bottom. So we come up till we find one line that represents them both. Then what we have to do is measure both of these angles. This is 18 degrees, which is a 61% loss of curve. This is a 12-degree kyphosis, which is a 129% loss of curve. Then we add the percentages together. 61 plus 129 is 190% loss of curve. So what we're actually looking at there is a lordotic S-curve in that neck like that with a double curve. And if you think about it biomechanically, that type of double curve is going to function really weird, isn't it? Compared to that normal lordosis, so C4, C5 disc interspace. So we're really getting abnormal function there. So same lines, that kind of tells us what to work at. Now, what we've been doing recently is using the head weights. Most of you are familiar with this. We're also putting glasses on patients where the top half of the glass has tape on it. And by doing that, they can't walk around like this because they can't see. They have to hold their head up. And by doing this, it starts to improve the cervical lordosis and decrease the forward head posture. And we're actually putting it together with head weights, and I found a new head weight called Halo Posture, which kind of goes on top here, so we can then take an x-ray to see how this is going to work. So pass the glasses around. You can pass that around too. And where's my other pair of glasses? And it's something as simple like this, just with the glasses, that starts to change it. Now I can adjust it in a position, but if it doesn't stay there, it doesn't make any sense to even adjust it. So this is the before, and on the third visit, this is an x-ray with a head weight in the glasses. See how that improved? We went from 140% loss of curve to an 18% loss of curve. We went from 2 inches of forward head posture, which is 30 pounds, down to normal forward head posture. So I'll tell the patient, I say, now see how bad your neck was there? Yeah. See how good it is there? Yeah. What did we do to get it from here to there? Well, doc, we had the glasses and the head weight on. And what are you going to keep doing? I'm going to keep wearing the head weight and the glasses. It's motivation, isn't it? Because I don't want this neck. They know this is bad. You know it's bad. I want this good neck. So we'll have them doing 20 minutes of head weighting with glasses twice a day. With proprioceptive neuromuscular reeducation, it takes 15 minutes to retrain the body and retrain the brain. It's called neuroplasticity. This is the X-ray code for a stress X-ray, 71001. If you use this code, guess what? Insurance companies will pay it. Now, this is a lady that came in. She had a 297% loss of curve, 23 pounds head weight, 1.3 inches. I just put 4 pounds of head weight on her without the glasses. She went from 297% loss of curve to 291% loss of curve, and the forward head posture decreased. Now, that's a good thing, but it didn't change. So then I just went with 2 pounds of head weight in the glasses. Together, she went from 297% loss of curve to 74% loss of curve. She went from 1.3 inches of forward head posture to 0.8. Then I went with 4 pounds of head weight in the glasses. She went from 297% loss of curve to a 52% loss of curve, and 1.3 inches to 0.1 inches of forward head posture. So in other words, this stress X-ray lets me see what I'm doing right. So which one did I have her do? 1, 2, 3, or 4? Yeah, exactly. Yeah, this on the third visit is when we always take the stress X-ray, so I can see how that body is responding. And then what we'll do is take a neutral lateral on the 12th visit. For example, then here's the patient on the first visit, 207% loss of curve. This is on the third visit with the head weight and the glasses on, went to an 18% loss of curve. On the 12th visit, we took another X-ray without the glasses, without the head weight. She was at 63% loss of curve. Okay? So that way I can kind of monitor this whole thing. Now, this is the patient card, and there's free copies of this on the website as well. Jay, why don't you just pass those out for me, okay? Date, percentage of loss of curve, forward head posture, C0, C1, C2, posterior vertebra, flexion vertebra, X-ray, extension X-ray, stress X-ray. So I've got all this marked down on the patient card. We actually have them do, this is the wobble chair to loosen things up, any cushion. We have them doing traction to get the curve back in there better. What? Yeah, when we do the traction, we have them face away from the wall. When they face towards the wall, they're leaning like this and giving them this forward head posture. When they lean away from the wall, it keeps that head straight, and what happens is they can't lean forward. So by having them face away from the wall, we're seeing much better results. Yeah. I keep changing things. Whatever works. So we've got traction units they come in and do, and this is just like a little clasp. Any hardware store has it. We've got chains here so they can adjust it for their height, because each person's height is different. So we have them do that. Sometimes I lay awake at night and ask questions. Is there any one thing a person can do to make his life successful? Back exercises. It's true. This is actually in the reception area. Patients who do not do their exercise will be dismissed and cheerfully referred to an office where they don't care. And guess what? I follow that. Yeah, I will dismiss patients if they're non-compliant, if they're not doing the X-rays. Personally, I don't care. I can do their exercises for them, but they're not going to feel any better. Remember I told you when I was real, 16, 17, the problems I've had? Well, I've been doing exercises for 36 years for my spine. Got a normal curve in the neck, normal curve in the back, and I like feeling good, and I'm not going to change that. Spinal hygiene is more important than dental hygiene. So I've actually, thanks to Kristen here, I have a full poster of this blown up in the office. So it's like pointing at the kids and adults to do their exercises. This says, do your exercise, I will gain weight. I sit on them until they promise to do their exercises. I am a motivational person. Have you noticed that? All right. So B.J. Palmer, what is straight chiropractic and what is mixing chiropractic? Because straight chiropractors would never do exercises, right? Although when you look at B.J. and what he was doing in Davenport, he had an entire area for exercise therapy. I've got the book, and this is back in 1948. And what he says is this: his clinic was founded for the restoration of health to those from whom medical treatment or ordinary chiropractic care has proved to be insufficient. Remember all the people that go to BJ at his clinic? He gave them exercises to do. Told the chiropractors not to give them exercises. Came back to his place, he gave them exercises and he got better. Where ordinary chiropractic care has proved insufficient. So they are important. We have them doing a spinal twist exercise. Everybody sit up straight. Accentuate the curve in your neck and your lower back and start twisting back and forth 25 times. After the age of puberty, the blood supply that goes to the disc atrophies and disappears. It needs motion for osmosis and imbibition. This gets motion in there. So this is a way of brushing your spine. Works for me. When you hear that popping and cracking, what's happening is the ligaments and discs are going from a hydrogel to a hydrosol state. They make gel out of ligament and discs from cows and pigs. Not because it tastes good, they do it because it has hydrosol, hydrogel properties, right? That's how you make Jell-O. Jell-O company doesn't want you to know that because they don't want you to know you're eating ligaments and discs from cows and pigs because people won't eat it. That's why they put coloring in it so it doesn't look like disc. Anyway, so that twisting exercise is real important to loosen them up. Then there's an extension exercise. Okay, we have them do that 25 times to work the extension muscles. Put your hands on top of the head and basically just bring your head into extension. Okay, right on the crown of your head and hold it for 5 seconds. Postural muscles respond to isometric exercising, not isotonic exercising. So doing this isn't going to do any good and it sucks. Doing this and holding it isometrically will. And that's what's going to change the spine. This is why they're saying exercises don't work for the spine, because they tried isotonic exercise and not isometric. We'll have the patient lie down and work the flexor muscles. Believe it or not, and I've spent a lot of time with Myologics muscle testing. We have found that in 99% of the people, the flexor muscles are about 50% weaker than the extensor muscles. It's the flexor muscles. So as the flexor muscles get weak, it causes more forward head posture. We have them doing this exercise 1,000,000 times a day, which works the extensors, which causes more forward head posture, which complicates the problem. So we really got to get those flexor muscles working. So we'll have them lie on a cervical roll and isometrically with the lordosis push their head upwards without allowing it to move, no motion. Now, a while back I was going to Panama to speak, and I went to a tanning booth to get ready so I don't burn. And I'm hyperactive with attention deficit disorder, okay? I'm honest. So I cannot lay in a tanning booth for 12 minutes without going completely crazy. So I'm lying there and going, all right, time's got to be up pretty soon. So I rolled over on my stomach and they had the cushion for the head there. So I started playing with it and I started pushing into this cushion. I said, when I do this, I can work the flexors and extensor muscles at the same time and get that cervical lordosis. So this is the sun tanning exercise. And I came up with in the booth. So what you do is just have them put 2 inches of foam underneath their forehead and have them push down. And what that does is it works the flexors and extensor muscles simultaneously and brings the curve back in the neck. This works really good. Again, it's isometric. We have them do it for 10 seconds, 10 times, twice a day. Then we do spinal molding where we have them, at night when they go to bed, they're going to lie on the towels. Remember we talked about the people that go to bed and use 2 pillows like this and wonder why they wake up terrible? Well, if they do the twisting exercise and then lie on a cervical roll at night, that Jell-O goes from a hydrosol to a hydrogel state after 14.5 minutes, so those curves are molded in there so they get a good night's sleep. So all my patients do the spinal twist exercise at night, and fortunately all hotels have towels, so I just roll up towels when I travel. And what I do is take it and fold it in half and then fold it in so there's about 1 inch down the middle and roll it up so it's soft in the center where the spinous processes are. About 3 inches is all you need. If it's sore, if it's too painful, you have to make it smaller. So that's how we have them do the spinal molding. We use a spinalator with a vibrating traction. We'll get into that in a little bit. There's a manual traction adjustment, MTA. And that's what this is. Okay, what we'll do is put this on the neck and kind of give a quick pull. Now, according to this book, Principles of Neuroscience, talks about Sherrington's law of reciprocal inhibition. Sometimes it is advantageous to contact the prime mover and antagonistic mover at the same time. In other words, when I give a quick pull with the manual traction adjustment, what happens is that protagonistic and antagonistic muscles in the neck will contract simultaneously, and when they do that, the flexors and extensors, it pulls the cervical lordosis in there by that quick type of an adjustment. And this actually came up from an old osteopathic technique right around 1959, and there were a couple different chiropractors that played with it, and I started coming up with some variations on it. Inferior atlas. The way we're going to adjust this is this is what we're talking about, the big important adjustment. We're going to go inferior to superior on that atlas. Now, give me just a second here, and this should be... A while back, I was out in Connecticut, and what we did is we had the DMX Works video fluoroscopy, and so I did some adjusting with the arthrostim on this patient. Now look at that loss of curve in that neck, okay? Now this is the arthrostim here, coming right into the atlas. Now watch, that atlas is going to move just a little bit, come down. See how that atlas just moved from inferior to superior? Right there. Okay, this is the very end of the arthrostim here. And now I'm going to just bring her into extension. Remember that severe loss of curve in there? So here's the adjustment, bringing her back into lordosis. There's the arthrostim. Okay, now we're done. Look at the change in the curve in that neck. I know, I love to see this stuff. Now here, we're going to adjust the rest of it. I'm going to go from a superior to inferior line of drive, and I'll explain this in just a second. So we're coming down here. What I'm trying to do, remember how all those lines diverge, the base posterior lines? So what I'm doing is trying to bring all those together, and this will get done real quick. Okay, see that curve? Okay. All right. Now we're done. Almost done. See how that curve came back in there again? Now that's cool, but we got to make it stay in position. So after that, then we can put the head weight and glasses on to make it stay. But being able to see that with the video fluoroscopy, with the digital motion X-ray, was so impressed me that I went out and bought a unit. All right. Manual traction adjustment. Hang on. I've been doing this thing. All right, all right. So what we're doing with that MT is really getting some of the meninges to release in there. This is what that adjustment looks like. If we have time, we can do it on some of the people here if you'd like. Starts to get that curve in there. Sometimes we'll use a mouth guard when we do it as well. I'm going to skip past this one. Just some various models of it. Now, this is a negative Z. We'll do an extension adjustment. This is a negative Z is forward adjustment to correct occiput and atlas, but that's only 20% of the time. We can also do it in extension. You could take a drop table and put a cervical roll on there and just drop them into extension when they have a restricted in extension. As a matter of fact, BJ did that same kind of thing. He used to use the hammer and chisel. There was a guy up in Duluth by the name of Stoner. And he and BJ had a running battle because he was into this hammer and chisel adjusting, and BJ just had to be by hands only. And this is from the book, Variations on Old Moves. The idea was to use that taboo question of traction. So anytime BJ found something chiropractors doing, he tested it out. While the patient was in the extended position, a blow was given. 15 minutes after, one man went home, took to his bed, and was dead. That simply shows what you're up against. The book is called Exposition of Old Moves. We also do a drop piece adjustment. What happens is when you get forward head posture, the shoulders round out and the ribs pull down, don't they? So what we'll do, and you can do this on any drop table, put a cervical roll in the neck and just do a P to A adjustment on the first rib and on the shoulders to bring it back. And what that does is allow that whole spine to start opening up. If I have rounded shoulders like this, it's hard to get that curve back in the neck. So one of the things we're finding is we get those ribs and shoulders adjusted posterior, it allows the lordosis to come back much quickly. 90% of my patients have a cervical lordosis in their neck after 1 week. Yeah. But this is why, because I'm looking at this stuff so closely. That's the negative Z adjustment, and it's just kind of going into extension. And again, you can use this with a drop table and just with a roll in there to bring them into extension. This is adjusting for that inferior atlas. We can do it sitting, flexion, extension, or for that inferior atlas I can have them lie down and just come with this inferior to superior line of drive on it. When we do that though, we have to go with a large double prong to get around the C2 spinous and get on that posterior arch of the atlas. So always use the large one like that. For the rest of the spine we're going to use a smaller one, which I'll show you in a minute. Okay. This is cervical spine flexion and extension that we just kind of showed you. Now, what happens with this cervical spine, when these vertebrae go posterior, these lines diverge, don't they? D.D. Palmer didn't say he was the first person to adjust the spine. He said, I'm the first person to use a spinous process, a lever arm to adjust the spine, right? So if I've got these areas diverging, instead of putting the head down and coming with the adjusting instrument trying to push from posterior to anterior, I'm going to come with a superior line of drive and push these spinuses down because they're all diverging. If I can bring those lines together, see how that's going to bring that cervical lordosis back into place? So I'm using a superior to inferior line of drive on that, which is bringing the curves back 3 times faster than trying to adjust it the other way. So this is an extension. Yeah, it's another type of extension. Z-axis, this is the hammer and chillet. I had 150 cases of paralysis reported that and looked up, found out they were brought up by the use of the hammer and mallet. BJ didn't like that. All right. Outcome assessment, being able to bring this back to normal. Okay, that's just the adjustment. I'll get into it. I use this on dogs too, and animals. And they brought this black lab in. He was angry. He couldn't walk on his front legs. And they took the adjusting instrument and started working on him. He goes, just happy, and got up and walked away normally. And I thought he was going to bite me. Works really good. And again, I like the arthrostim. I've tried a bunch of different ones, but the arthrostim does 3, 6, and 12 times per second. The nervous system fires at around 333 milliseconds, which means you can blink your eyes in about 3 seconds. So I can come up to Jay here and push him, he's going to come right back. But if I push, 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 see how I can overcome that? The arthrostim at 6 times per second comes out to 167 milliseconds. The nervous system is 333 milliseconds. So it's sub-neurological threshold, so I can actually see these changes. On pre and post x-rays, we're actually getting those bones to actually move. I did just basically chiropractic manual adjustments on patients just as an experiment, manual manipulation, took post x-rays, and there were no changes at all. Okay, the only way I can change the spine is with the adjusting instrument. Now I still do manual adjustments on like the rest of it, but so this is the superior going into extension, Sutherland video fluoroscopy. So this is the P to A, superior to inferior line of drive I want to get to push all those spinuses together and then into extension. Now again, on the website a while back I wrote a book, an adjusting book, Pedibone Spinal Adjusting System. You can download it for free that goes through all of these. I actually helped write part 4 of the National Board. Some of you are probably mad at me about that, right? I wrote part of the adjusting parts of that and helped them out. So I used the same format from part 4 of the National Board when I wrote this book. But again, it goes through doctor position, patient position, line of drive, the whole bit. This is Dr. David Butler's patient, and here's the post x-ray. So actually she went from, 110% loss of curve to a 10% loss of curve. And the one thing I'm seeing here, okay, notice how these vertebrae have all gone posterior. Now in the post x-ray they're all looking better except for C6. So, which one am I going to go work on? Big red truck, right? Yeah. So that, you see, the x-rays show me what I did right and what I did wrong, and I do a lot of things wrong, which gives me the opportunity to turn around and do these things right again. This is that rib adjustment we talked about. Thule tables makes those speeders, but they also have some really good drop pieces that we use for some of the adjusting. This is like a 17 by 14 inches. This is for some of the cervical adjusting. Now, in order to make the spine function properly, we have to mix, fix, and set it. All right? A while back, years ago, we did a seminar up in St. Cloud, Minnesota. Adjusted a bunch of chiropractors. Monday morning, 2 of the chiropractors had so much back pain they couldn't work because we were cold adjusting. If you went to, a few years ago I broke something, I don't even remember what it was, but I took it to the garage, and what I did is I took my epoxy glue, we take the 2 different types of glue and you mix it together. So I mixed it up, and then I took the broken pieces, put glue on it, and I fixed it into position. I fixed it. And then I had to set it to let it harden and stay there, didn't I? Well, guess what? We've got to do the spine the same way. We've got to mix it up, warm it up, to get it ready for the adjustment, fix it into the proper position with the adjustment, then let it set and stay in the adjustment afterwards. So that's the mix-fix protocol. So the wobble chair, the muscle stem, the adjustment is the fixing, and the setting is a lot to do with spinal weighting and vibration. But where you start shows where you're going to end up. So I got up in the morning, and I was off by 1 button, and look what happened. Okay? So I walked into the office and said, "Take a picture of me quick." And my office staff's going, "What?" I said, "Just take a picture." So there is a sequence. You all heard about the bridge in Minneapolis that fell down a year ago? Remember we talked about the spine kind of being a bridge compared to an engine? Do you want it patched or do you want it fixed? If they would have fixed the bridge, it wouldn't have collapsed. I haven't used that yet in the office much, but traction, we're going to face away from the wall. They're going to do about 61-second repetitions. When they go down, they're going to exhale. When they go up, they're going to inhale. Down, exhale, up, inhale. It's going to take about 1 second. And that way, if they're doing it too fast, they hyperventilate and they pass out. So it's the kids that are lying on the floor that aren't doing this properly. I can tell when I walk into the room. This is what the traction actually does. I took an x-ray in the traction, opens up the disc space, opens up the IVFs. We get them all lined up doing the traction, and we have a pretty fun time in the clinic doing this. Yep?
What's the difference if you do them facing the wall?
If you face the wall, what's going to happen is they have a tendency to lean forward and increases forward head posture. Whereas if they're going straight down, it's not a problem. But too many of these kids are, they take them at home and put it at home on the door, and when they face the door, they start doing this, okay? Whereas if by doing it backwards, there's no way they're going to go create forward head posture. And someone that has a hyperkyphosis, you want them definitely facing away from the door. Straight down, there's no problem. This is the head weight. We have a lady that makes these out of California. This is the core stem and the muscle stem, which is a modified Makita drill or jigsaw that works really good. Talks about the disc wedging. On the inside, the ligaments get tight. On the outside, the muscles get hypertrophied. This is the vibrating traction. What it is a spinal roll that vibrates at 4.5 hertz. Ligaments and discs will relax at 4.5 hertz. For example, we can use it in the neck or the lower back. We put them on it for about 5 minutes. This is amazing how it helps cervical and lumbar disc herniations because it brings that curve back in. Truck drivers have a lot of problems with the backs because of the vibration of the diesel engine, which comes out to about 4.5 hertz. What happens is that frequency will actually make the ligaments disc relax, so it compresses down. Well, all we did is took that same frequency and put it into a vibrating traction that brings the lordosis in, which allows the ligaments disc to relax to bring the curves back in much faster. There's our truck driver. It allows the body to get osmosis and imbibition. When you look at the vertebra, you have to realize that the fluids are going into the disc through the end plates and then out the sides of the vertebra, and it's a constant motion. But for osmosis and imbibition, for disc metabolism, it's going through the end plates. So we've got to get that motion in there. So we can do it on the cervical spine, lumbar spine. Just some more research verifying it.
How long do you have to make?
We usually have to do it for like 5 minutes, maybe 10 minutes max, is all that it takes. But it brings the curves in much faster. This is a kyphosis. This is in 4 days by using the vibrating traction with adjustments too. Bunch of testimonials, and a bunch of research on it. Sometimes we'll actually use a catcher's mask with weight on it to decrease the forward head posture if they have a normal curve. Andrew Carnegie says, as I grow older, I pay less attention to what people say and I just watch what they do. Dr. Lee Eckerd passed away about a month ago. Really good friend of mine and helped a lot in regard to what we're doing with scoliosis. And he actually came up with the Eckerd table. Does anybody have a flexion distraction or Eckerd table? One thing I want to take a look at, we put them on here for scoliosis on a mirror image. But I want you to see this. Where is maximize living? Here it is. This is a patient on the Eckerd table. But look what it's doing to their cervical spine. So this is the flexion and extension table. Look at the motion of getting into these discs here. Look at how these discs are opening up, how we can get motion. We think that these tables are only for the lower back. So we did video fluoroscopy, DMX, digital motion x-ray. Look how it gets those discs moving in there, stretching the anterior longitudinal ligament. And he's actually holding her head down here. And even without the head being held down, we're seeing a lot of motion. What we'll do is put the face piece up a little bit and put them on that to get that motion into the disc. But I think it's just fascinating to be able to see what's really happening there. All right. And then the next thing we came up with was the vibrating traction, or the vibe. This was one of the first prototypes. There was an article a while back by a guy named Rubin, and he'd put sheep on a vibrating platform and increase the bone density. So my feeling at that time, back in 2000, was if I had a kid that had a wedged vertebra, I could put them on this vibrating traction, do spinal weighting to bring their spine in the opposite direction, and through the changes of the spine, get the body to actually remodel in there. And we've seen some pretty good changes with that. So I invented the vibrating platform, and it starts doing a lot of other things. Muscle strength, decreases pain. This inflammation, you got just a glass of water, but see how it's bubbling on there? So any areas of inflammation really make a big difference. Okay. So it's like people get on and say, oh yeah, I feel this funny thing in my ear. Well, they've got ear inflammation. It starts to affect my sinuses. And I did the same thing with kitty litter. And who's got the Wii machine, the Wii game? Okay, do you have Wii Fit? Isn't that cool? What you can do, I had to get 2 of them, and I got one in the office, but there's a balancing stand called Wii Fit, and so we can actually check the balance of these patients. So what we've been doing is checking their balance and putting them on the Vibe after that for 5 minutes, then coming back and doing the Wii Fit after that, and what happens is their balance comes back to normal, and their center of gravity comes way down to the middle, and their sway pattern comes back to normal. Because that vibration is like a shaking pattern. After you adjust them, you put them on the Vibe, and it makes the adjustment stay corrected in that position as they reorientate in time and space to their new environment. So we've just been having a good time with that, and I like their golf game too. It's about the only time I get out. So we've done a lot of work with this, with the vibrating. This was actually the article that came out 2001, where they put sheep on a vibrating, the back feet of the sheep on a vibrating platform, and increased bone density by 33%. And this is actually microscopic pictures of these sheep's bone, not just the outer cortex, the inside as well, which is pretty amazing. I've got one friend of mine, and his mother, she's 82 years old. She's got the Vibe at home. She did it for 1 year, went in, and the doctor said, well, your bone density is increased by 5%. Keep taking that Fosamax. She goes, okay. She goes back the following year, and he says, now your bone density is increased by 10%. Keep taking the Fosamax. And she goes, I haven't taken that stuff. I stand on this vibrating platform. So in 2 years, her bone density has increased 15%. And this is another lady. Yeah, Fosamax. Fosamax is what they used to clean toilets with. Same chemicals. Years ago, I broke my foot. I was doing something, and I landed the wrong way. So I did a double compound fracture of the 5th metatarsal. And I stood on the Vibe for 10 minutes for 5 days in a row. At the end of 5 days, I was doing a seminar running around and told one of my doctors that I had broken my foot. He says, you don't have a broken foot. There's no way you could be running around like you're doing with a broken foot. So I pulled out the x-rays. I said, yeah, here's where it is. You see, it's a double compound fracture there. And 10 days later, it was just about completely healed. So I went, I like this. So I did a little more further research. Last summer, I broke my arm when I was making some scoliosis equipment. So I just kind of got on the vibe, and I put a stick under there and got this vibrating. And actually, I set it myself, went into the emergency room, and said, oh, you set that. How come? I said, because it was out of place. I mean, big red truck, right? Hello? And anyway, they said, well, you're probably going to have surgery. And I started doing this, and right now, it's like 99% back to normal. But I did vibration therapy on a regular basis with it. And as part of changing the whole thing, bunch of testimonials on the vibe. This is probably TMI, but my wife and I have a vibe in our bedroom. We could actually have him do traction on the vibe at the same time. I got one guy who would come in all hunched over. He'd stand on this for 5 minutes. He was 78 years old, and he walked out straight, and he would stay that way till like for 6.5 days later, and he'd come and he started to be bending over again. So the vibration is kind of a proprioceptive neuromuscular re-education as well. And I had to get them in. This is my grandson Elijah, and that's my grandson Tristan. And they love the vibe. These little kids will get on it and just stand on it and giggle. It's fun. Exercises, spinal twist exercise, spinal molding. This is part of the therapy as well. Now, this is another article I came across. When we're talking about this spinal molding, remember I said you make gel out of ligaments and discs from cows and pigs. What we want to do is actually lie in this at night. First we do the twisting exercise. Twisting creates motion. Motion creates friction. Friction creates heat. What happens when you heat up Jell-O? It becomes a liquid. It goes from a hydrogel to a hydrosol state. And then we have them lie on these supports for 15 to 20 minutes, and it'll actually start to mold those curves in there. Now, after that amount of time, they can pull them out and roll over on their side, not on their stomach, of course. So we'll actually have them do that spinal molding. So it's important. Now, this is an article I found in April of 2008. Skilled adaptive formulas are significantly reduced in spine position by lateral fulcrums. What they did is they had the scoliosis patients lie on a lumbar fulcrum. Remember, when they lose the curves in one dimension, the body puts them in another dimension? And, must have missed it. Anyway, it significantly reduced the scoliosis by when they took a lying down x-ray on the fulcrum. Okay? So it was real important to get that there. So when we start to look at putting all this together, we want to do a posture exam on the patient. Look at them. Do they have forward head posture, head tilt, high shoulder? Look at their posture. We want to be able to take x-rays and analyze those x-rays. We want to go through the mix, fix, and set. Get them ready, get them adjusted, get them to stay in adjustment, and get them out, right? So different types of protocols. So here's the x-ray. Here's the flexion x-ray. Here's the extension x-ray. So then we're going to have them do the wobble chair. Now, in my reception area, I have 6 wobble chairs. So when they come in, they can't find the normal chair. They have to sit on this chair, and they start wobbling back and forth. So from the second they walk into the office, that's proprioceptive neuromuscular re-education, right? Which is an ICDA code that you can charge for. Because I get paid for making my patients wait. Not a bad idea. But it gets that spine warmed up. Then they're going to do their traction, and then the vibrating traction. And then we can do the Eckert table with the muscle stim, and then we'll do the adjusting. Now, I lost this part, and I got a presentation on it, but there's a reciprocal influence of levers in the body, and this is real important. In other words, the cervical neck should have a normal lordosis, the thoracic has a kyphosis. Well, when I lose the cervical curve, the thoracic curve reciprocates and tries to go anterior. So it's a reciprocal influence of curves. Anytime you have a loss of cervical lordosis, what happens is that thoracic spine will start to go anterior. Now, the thoracic spine doesn't want to go anterior because it's fixed because of the ribs. So what happens is it goes forwards, it gets jammed. What's the normal motion of the thoracic spine? Lateral, isn't it? So what happens is this starts to go forwards because of those forces pushing, it starts to buckle off to the side laterally. And then when that happens, we have what is known as Pottinger's saucering. So what you have to do with anybody that has a loss of cervical curve or forward head posture is never adjust them P to A on the middle of the thoracic spine. Because all you're going to do is jam that up. As I push this thoracic spine straighter, I'm going to take that cervical spine and make it straighter, aren't I? Reciprocal influence of levers in the body. So all anterior dorsal adjusting. Now the one thing that we find with scoliosis, and I wrote another paper on this, is all kids with scoliosis have anterior thoracic vertebra. As a matter of fact, this has been verified in the literature over the last 25 years. That not one guy actually went out and said, I looked at all the old x-rays, all the old osteological museums, everything I could find on a scoliosis patient. Every single one had anterior dorsals, known as lordozation or Pottinger's saucering. Now, if you think about it, what happens with these kids is they got a straight neck, this starts to go forwards, and then it starts to deviate off to the side. Puts that additional curve in there. What happens when we start to put a P to A force into that thoracic spine or trying to adjust the high side of the rainbow on a scoliosis patient? You're actually taking that and bringing it more posterior to anterior, and what's the body going to do? It's going to buckle it off to the side more. Never ever adjust a scoliosis patient P to A on the thoracic spine or on the high side of the rainbow, or you're going to make them worse. I had a doctor call me up about a year ago and said, yeah, you know, this girl came in, she was at 18 degrees, I've been adjusting her 3 times a week for a year, she's now at 50 degrees, what do I do? Duh, big red truck, stop adjusting her. Negative Z adjustment, and you can do this with an adjusting instrument, you don't have to have that drop piece to do it, you're just going to come with an inferior superior line of drive on the occiput. More important is that extension adjustment, bringing that back into extension. And then the adjusting for that inferior atlas, or the inferior to superior line of drive. Now what I'm doing is contacting this inferior atlas on the posterior arch. Here she's sitting, I've got her in flexion, like we did with the video thoracoscopy, P to A on it, then I can also bring into extension, and then I can also have her lie down prone and come with an inferior to superior line of drive. Start looking at your x-rays. When you see this inferior atlas, start adjusting your patients with it. It's going to blow you away the differences you're going to start to see with that spine. This is the third dimensional component of the vertebral subluxation complex that we've been missing in chiropractic. Here's the superior to inferior adjusting. Okay. And after that, then we put them on the vibe and let them stand with the head weight and the glasses. We can do side weighting as well, but primarily for the cervical curve. Just standing there for 5 minutes will allow this whole thing to set back into place. Mix, fix, and set again. And then they have to do spinal molding as well. Cervical and lumbar, and this is at night, not in the office. We just teach them to do it at night at home, like we talked about before. John Wesley is the founder of the Methodist Church. He says, when you set your soul on fire, people love to come and see you burn. When you set your soul on fire, people love to come and see you burn. How many of you ever driven around and followed the fire trucks and gone and watched a fire? Okay? Yeah, people do it all the time. Some of you are lying to me, okay? That same way, if you are on fire about what you're doing, about chiropractic, people will come. What month is it? August? Right now, my next opening for a scoliosis patient is until February of 2009. We're booked that far out, okay? And I can't even see regular patients anymore. And I mean, once in a while. But I mean, it's like, you know, you talk about a waiting list practice. February is a waiting list practice, right? But when you're on fire, people are going to come. When you know what you're doing, when when you know in your heart this is what God wants you to do, and He's leading you down that path, when your soul is on fire, there's no shortage of sick people out there, people. The other thing John Wesley said, first of all, God never blesses an individual just for that person's exclusive benefit. God calls each of us to be a blessing to others. And we see this in all the stories in the Bible as well. John Wesley said, do all the good you can, by all the means you can, in all the ways you can, in all the places you can, at all the times you can, to all the people you can, as long as ever you can. I like that, okay? This is what gets me out of the bed at 4 o'clock in the morning. It's like I wake up and my brain just kicks in. I start thinking about stuff. And I'm so excited. I'm 57 years old. I've been in practice for 34 years, and I can't wait to get to the clinic and start working on patients. I get there 2 hours before my first patient shows up, just so I can get ready. Just stuff that is fun to do, okay? I had to finish this on time. So, the end, or the beginning.